problem going on. So we'll define it further, but first let's start with a case. So there is a 32-year male who collapsed during a long session in a squash court. His elder brother had a sudden death a couple of years while participating in a 100-meter dash. What are the possibilities? So what do you think are the possible reasons behind this situation?
So what's the reason? Two family members have problem. One collapsed and was revived. The other one died. What are the possibilities? So it may be hypertrophic cardiomyopathy. Good. What type of hypertrophic cardiomyopathy? There are many varieties of hypertrophic cardiomyopathy, at least 4 of them. So it is subaortic stenosis or hypertrophic obstructive cardiomyopathy. There are apical cardiomyopathies which may not be that consequential, but the cardiomyopathies which are causing problem, asymmetrical hypertrophy just close to the left ventricular outflow tract, they can cause such problem. What else? What else could be the possibility? Do you think it's only one possible disease? Yes, good. A long QT can be a problem. Any other disease? Aortic stenosis. But aortic stenosis generally does not come in younger patients and doesn't have very strong family history. So considering the family history and the young age of the people, hypertrophic cardiomyopathy is the most likely underlying pathology. So we start now with cardiomyopathy.
So starting off with the cardiomyopathy, it says primary diseases of the myocardium. Now what does primary mean? It means that if the myocardium is being affected as a result of some other cardiac issue, for example hypertension, or a coronary artery disease, or a valvular heart disease, or say a congenital heart defect, these are not grouped under the heading of cardiomyopathies. So it needs to be an intrinsic problem, a primary disorder of the myocardium.
So primary generally means we do not know the cause of it. It's idiopathic type of cardiomyopathy. We've got primary cardiomyopathy, we've got secondary cardiomyopathies. Secondary cardiomyopathies means we have identifiable anatomical or physiological defects. In primary cardiomyopathies, we do not have clear identifiable cause. So this term excludes cardiac dysfunction that results from structural heart disease such as coronary artery disease, valve disease, or severe hypertension.
Now how do we classify? As Sir just mentioned, there are cardiomyopathies categorized into primary and secondary varieties. So primary is idiopathic. We cannot trace out a particular cause for the disease. Whereas secondary, we do have a cause. The cause can be a systemic disorder going on in the background, a metabolic defect, an infection, or it can be a sensitivity, or it can be a result of toxicity. All today's discussion will involve the 3 major varieties of cardiomyopathy, which are dilated cardiomyopathy, hypertrophic, and restrictive cardiomyopathies.
So we have 3 varieties. The heart is big, the heart is of normal size, the heart is slightly smaller. So you've got a range starting from a larger heart to a smaller heart. Actually, the heart is not very small, but when you compare in restrictive cardiomyopathy, even on imaging, you see the heart looks a little smaller.
So let's discuss the first variety, that is dilated cardiomyopathy. Now, as the name suggests, this is a big heart. Especially the ventricles, and in particular the left ventricle has dilated pathologically. Now, because of this immense dilatation, an effective cross-bridging, an effective linking between the actin and myosin chains not there. The cross-linking is not enough to produce an effective contraction. Also, another problem is that the thickness of the walls is reduced. Because of thin walls, an effective contraction is absent.
So what's the law which governs this basic principle of cardiac contraction? Frank-Starling law. The larger the radius, do you have any heart failure when there is normal or preserved ejection fraction? So this is a disease producing heart failure with reduced ejection fraction. There is another heart failure with preserved ejection fraction, that the heart is normally ejecting. What is that disease? You see the word systolic dysfunction, and there is a term called diastolic dysfunction. You see, the heart is different from lungs. Both contraction and relaxation are active process. While in lungs, chest expansion is active, and chest, when it collapses, it's because of the elastic recoil. It does not require energy. It's not an energy dependent process. So in heart, both are energy dependent process. There is active contraction and active relaxation. So if the heart contracts normally, it has a normal ejection fraction, but it relaxes poorly. That means the end diastolic pressure is going to rise. That will result in heart failure. So patients have preserved ejection fraction, but they develop pulmonary edema. This happens in patients who are diabetic, those who have hypertrophy because of the hypertension, or in hypertrophic cardiomyopathies as well. So we've got, in this type of disease, we've got systolic dysfunction, while the other disease we have got diastolic dysfunction. And you can see on echo, the diastolic dysfunction can be seen on the echo.
So what are the different varieties of dilated cardiomyopathy? As we discussed earlier, it is idiopathic, the most common, and that will be called the primary disease. And then we have a number of secondary causes of dilated cardiomyopathy. Let's just go through them. So idiopathic, that is primary. Then there is inflammatory variety. Infective, like an infection, viral infection, the Coxsackie B virus. Toxic, like alcohol or cocaine. There's a variety that is SUPO, that is similar, that is also known as a broken heart syndrome. And what happens here is that the systolic disorder is as a result of sudden emotional distress.
So if you've got a broken relationship, you've got a loss, you fail miserably in final professional, you may have this. What does this actually mean?
It means octopus pot.
A
Because
pot-
it is apical.
The pot used by the Japanese to trap the octopus.
Another variety is pericardium, and it occurs usually late in the gestation period, usually late in the third trimester. It can also occur postpartum, usually we keep a target of 6 months, and it's mostly a reversible condition.
So most of these, other than idiopathic, this infective, this broken heart, this peripartum, this infective, inflammatory, may reverse. These generally reverse. This does not. Idiopathic variety does not reverse. The others may, to some extent, if you take the offending agent, they might reverse. The cardiac function may improve.
If you have noticed, as per the picture of vitamin B1 here, this is related to thiamine deficiency that can also cause dilated cardiomyopathy, the very, very heart.
So you see the other reasons for dilatation of the heart, they may improve, for example, thyrotoxic heart. That will improve. Hypothyroid heart, that may improve. So, but the idiopathic variety, remember, does not improve. If your patient improves, it means your diagnosis was not correct.
Now, what are the clinical features you find in a patient with dilated cardiomyopathy? Since this is a failing heart, and you can have features of right-sided heart failure or the left-sided. So, before we move on to the slides, let's have a general discussion. What do you think? What sort of congestion develops in a patient who has left-sided heart failure? What sort of congestion? The pulmonary congestion. And a person with pulmonary congestion will present with what symptoms? Yeah, dyspnea, yes. Orthopnea. And PNP, that is paroxysmal nocturnal dyspnea. So that is what's happening on the left side. If you move on to the right side, what sort of congestion? The systemic congestion. So what are the features of a systemic congestion? Edema in the independent parts, edema. What will happen to the liver? The liver will be under stress when the patient may present with a painful abdomen, and when we look at the abdomen, it's tender, we might find ascites. And what else? What happens to the JVP? Will it be raised or will it be low? What happens to the JVP? It will be raised. The central venous pressure will be raised.
So why do you develop pulmonary congestion? There is discrepancy in the output of left heart and right heart. The left heart is not ejecting, the right heart is normally ejecting. So pulmonary venous congestion and arterial congestion starts. So it is the difference between the cardiac output of the left side of the heart and the right side of the heart. If both hearts are weak, you're probably not going to have that much congestion in the lungs. So it is the discrepancy between the left heart and the right heart. Left heart is not ejecting, the right heart is ejecting normally, then you have this pulmonary congestion. So we move on to the next slide. We already discussed this thing.
And also, since this is a low cardiac output state, some other features include a low volume pulse, patient will be having fatigue, weakness, and some complications like arrhythmias and also thromboembolic conditions.
So you remember this thing, low volume pulse, it is very important. When you are examining the short case, you are asked to examine the heart and you find a low volume pulse. There are only possibly three diagnoses. It is MS, it is AS, or it is weak heart, maybe cardiomyopathy or whatever. So cardiac output is low. So there are three states when you are given in the examination. Examine the heart of this patient, put a hand on the pulse. If the pulse is weak, these are the three possibilities. And if the pulse is bounding, there are only possibly two possibilities: aortic regurgitation, mitral regurgitation. So just having the pulse. So when you go for short case examination, you should have scheme in your mind. Immediately go for the most relevant examination that will give you a clue what is the possible. For example, if you are to examine the back of the chest and you find chest is hyperinflated, this is obstructive disease, nothing added. It can be asthma or COPD, that's it.
So how are we going to diagnose a case of dilated cardiomyopathy? The first thing is we can go for a chest X-ray. The CT ratio, that is the cardiothoracic ratio. If you look at the first image of we take a ratio, normally should be less than 0.5. But what happens in a dilated heart, the ratio gets more than 0.5.
So what you see in this X-ray, you got an orange line here and a blue line here. There are some white lines here. You can see these vertical lines. So it's actually the maximum diameter of heart. And you see the orange line ends here, but the white line is not ending at this border. It is perpendicular to this edge. So you take the maximum diameter of the heart. You take the midline, maximum to the left, maximum to the right. They may not be in the same horizontal plane. So you combine, that is the cardiac size. And the thoracic ratio is the inside of the ribs visible, not the outer border, it's the inner border of the ribs. So maximum inner border and maximum outer border of the heart, you take a ratio of this. This is CT ratio. If it exceeds 55, it is definitely cardiomegaly. Next.
On an X-ray, you can also find pulmonary congestion and pleural effusion. Next, you can go for ECG. And what do we see on ECG? Abnormal Q waves, conduction effects, heart blocks, ectopics, and atrial fibrillation. If you have noticed, I've put gold bars, picture of gold bars. That is for echocardiography. That is the gold standard. On an echo, what do we see? As we discussed earlier, there is systolic dysfunction. So you will see a heart that is not contracting properly. You will see a heart with thin walls. And you will see dilatation, large chambers.
So you see the size of LV cavity, the RV cavity, and you see this is LA. And you can see thinned out septum. We don't see the outer wall, but you can see it's thinning out here.
Okay, so while I was preparing the presentation, I came out with a question and I couldn't find any answer. So why are the ventricles above and atria below in an echo?
It depends upon the probe and the orientation of the probe. So you can rotate it and you can find. So it's the probe, how you put in the probe. The image will depend on that. But generally the view we get, this is an apical view. So it is seeing the heart from this side. So it will mean this portion will look above.
We go over cardiac catheter studies, but only if we suspect coronary artery diseases. And then we have endomyocardial biopsies, not routinely done, but if they need the evidence.
So if we are considering that our diagnosis is not idiopathic cardiomyopathy, it's some sort of inflammatory myopathy. For example, if it is associated with vasculitic disorders or autoimmune disorders, if you are considering that this is an inflammatory myopathy, you want to know exactly what type of myopathy is, then you may go for an endomyocardial biopsy. Otherwise, generally, if we've got the peripheral reports, the inflammatory markers, the other blood reports, the clinical picture of the patient, if that suggests that this is idiopathic type of cardiomyopathy, we don't need the biopsy. It's done in only a few cases.
So now let's manage. Our target for a patient with dilated cardiomyopathy, our target is to reduce the preload or reduce the afterload so that the stress on the heart is reduced. So what can we do to reduce the preload? Dietary modifications, first and foremost, low sodium, low water diet, and glycine and what sort of glycine can reduce the preload.
So before we go to the dietary restrictions, we go for physical limitation, physical activity restriction. The patient should not exert too much. The exercise should be encouraged, but within the patient's capabilities. Don't ask the patient that you should ride up Minar-e-Pakistan. So limit the physical activity so that the patient does not become symptomatic. But you should advise some degree of exercise should be routinely done. Then we go for the dietary restrictions.
So first you classify the patient according to the anti-aging classification, and then that's how we'll go to the lifestyle modifications. So as I was mentioning, dietary restriction, and I was saying what medication can reduce the preload, the diuretics. And is there any medication that can reduce the afterload?
Is there any other medicine which can reduce the preload? You give diuretics, it's going to cause shrinking of the volume. that's going to decrease the venous return. But is there any other drug which can decrease the venous return? Which drugs? Nitrates can be used. Nitrates cause venodilatation, and they can increase the size of the capacitance vessels so that the venous return improves. When you decrease the venous return, the size of the LV cavity shrinks, and that may improve the contraction.
The afterload can be reduced by making use of vasodilators like ACE inhibitors and PRPs. Why do we use beta blockers? The beta blockers actually prolong the diastolic phase of the cardiac cycle. And due to this reason, there is better perfusion of the coronary arteries, and better perfused coronary arteries lead to a better contracting heart.
So they not only decrease the force of contraction, which reduces myocardial wall tension. That means that will decrease the oxygen requirement. And since it prolongs diastole, it means it's going to cause better perfusion of the coronary arteries. So the oxygen requirement of the heart can be met more appropriately if we use beta blockers.
Now, if everything fails, the only option left is to go for a surgical correction. We can place ventricular assist devices since we need to provide assistance and help to the ventricles. We can place defibrillators to prevent sudden death, because defibrillators will make sure that there is no kind of atrial fibrillation and any other sort of arrhythmia development.
So it's not actually for atrial fibrillation, this is for ventricular fibrillation. If the patient develops ventricular fibrillation and sudden death in the family, and they have cardiomyopathies, then this ICD may be used.
We can go for surgically reducing the size of the left ventricle, that is by LV reduction procedures, and these we can do the cardiac transplantation.
So LV reduction procedure is if you cut some part of the myocardium and then stitch it, it means the cavity will become smaller. That may improve the contraction.
Lastly, we have the cardiac transplantation. So that was all about dilated cardiomyopathy. Let's begin with hypertrophic cardiomyopathy, and things will be different here, especially the management. So, dilated, as opposite to dilated, hypertrophic is mostly a genetic disorder, and the pattern of inheritance is an autosomal dominant. So there are gene mutations in the sarcopenic proteins, the contractile proteins troponin and beta-myosin. So now this is a case of diastolic dysfunction. The walls are thick, this is a hypercontracting heart, and it's unable to be filled up properly. Stiff hypertrophic ventricle, and this is important. In case of septal hypertrophy, the interventricular septum, there will be an obstruction in the outflow tract of the left ventricle. This will be discussed in the next slide, so I need to emphasize it enough here, that a septal hypertrophy will lead to left ventricular outflow tract obstruction.
Asymmetrical septal hypertrophy, that's important. That's the one variety which is more serious.
What are the clinical features? Syncope, angina, dyspnea, palpitations, arrhythmias, cardiac failure. Sudden death in young athletes, as we started off with the case scenario.
Almost same as in aortic stenosis. Do you remember? Very similar.
There will be a jerky carotid pulse. And what we find is an ejection systolic murmur. This is important, and we'll discuss it in a bit of detail. Now, due to the outflow tract developing late in the systole, we find an ejection systolic murmur. But this murmur, the intensity can vary based on preload and afterload. So I made a hint that is more preload and more afterload increases the size of the ventricle, and it's able to overcome the obstruction. So there will be less obstruction. More preload, afterload, less obstruction, and a less intense murmur. On the contrary, if the preload is reduced or if the afterload is reduced, the obstruction will be more. There is an inverse relation. And so the intensity of the murmur will increase. These are some of the activities that I mentioned. Squatting and sustained hand gripping. Squatting increases the preload. Hand gripping increases the afterload. And so we have less obstruction. Standing and Valsalva will reduce the preload and cause more obstruction. So I think leg raise should be.
Yes. Yes.
Leg raise here is mentioned wrong. That's by mistake. It should be mentioned with the above hand. Leg raise comes more after.
So it's going to increase the venous return when you raise the leg. It's going to increase the venous return.
So I hope I just made it clear. The leg raise should be mentioned with the above hand.
So this small mistake can be ignored.
So diagnosis. A family history since this is a genetic disorder. An ECG, an echo. What do we see on an echo? There will be hypertrophy, thick walls, and a heart which is contracting vigorously. We can go for cardiac MRI, genetic testing, and biopsies. What is the management for a patient with hypertrophic cardiomyopathy?
So I will hold you here. This investigation, cardiac MRI, it's a very beautiful test. It's a recent addition to the diagnostic armamentarium of heart. So this test with perfusion studies gives you a very good indication that where is the problem and what is the most likely type of problem. Yes, move.
Lifestyle changes.
What lifestyle changes?
What sort of lifestyle changes do you think? Exercise.
Strenuous exercise.
Vigorous sports are to be avoided.
Avoided.
And here we are not going to advise the patient to go for a low sodium or low water diet because that too increases the preload. So here the management is a little bit different. Negative inotropic drug, beta blockers, calcium channel blockers. Can combine that with diazepam if the patient is not responsive to beta blocker alone or calcium channel.
So do not use digoxin in these patients, never.
As I just mentioned earlier, diuretics and vasodilators should be used with caution. Surgical options. We can reduce the hypertrophic septum by means of alcohol septum ablation, or we can go for myopathy. And lastly, we have the option of cardiac transplantation.
Next.
Okay, lastly, we have restrictive cardiomyopathy, and I'll try to cover it in 5 minutes. So, pathogenesis. Here, it is a stiff heart again, and it is also a diastolic dysfunction, but here the problem is not hypertrophy, it is infiltration. And I'll just mention the diseases which can lead to this condition. The causes can be autoimmune, that is scleroderma, or it can be an infiltrative disorder, amyloidosis, sarcoidosis, hemochromatosis, or it can be a storage disorder such as Fabry-Herder or glycogen storage disorders. So these conditions can lead to a restrictive cardiomyopathy, and here I should mention that this condition should be differentiated from a constrictive pericarditis.
So you've got the cardiomyopathies. One is the failure of contraction, dilated cardiomyopathy. The other one is vigorously contracting heart, forcefully. The third one is not very contracting, not relaxing. It's a restricted movement. So there you have got a poor contraction, got a vigorous contraction, and you got minimal contraction and relaxation.
So what are the clinical features? The clinical features of all three conditions are almost similar. So we have dyspnea, exercise intolerance, features of heart failure, right-sided more commonly found, arrhythmias, and elevated JVP and expiration.
What is this?
The Kussmaul sign.
The Kussmaul sign. During respiration, normally JVP falls in inspiration. In this condition, the JVP rises during inspiration. So this is paradoxical rise in JVP.
The diagnosis. There is one use of a chest X-ray and ECG and echo. What will an echo show? An echo will show biatrial enlargement. Here Here the ventricles are not enlarged, here there will be bilateral enlargement. Symmetric wall thickening, you can go for an MRI, and catheter studies only when we want to see if there is problem with the pulmonary arteries and around.
So the catheter studies may also sometimes be required when you have to differentiate this from constrictive pericarditis. In some cases, the diseases may overlap to such an extent that it may be required to have catheter studies to actually differentiate this from constrictive pericarditis.
So what is the treatment? Since the cause is somewhere else, we need to treat that cause. Treat the underlying pathology. And as the symptoms arise, for example, symptoms of heart failure or thromboembolism, that needs to be corrected accordingly. Here again, we will be cautious with diuretics and vasodilators because they can compromise the already compromised cardiac output.
So anticoagulation is also required in patients who've got dilated cardiomyopathy because there is a risk of thrombus formation. There is poor contraction of the heart, there is stasis of the blood that may result in clot formation and that may embolize. These patients tend to have atrial fibrillation as well. So chances of having thrombus formation inside the heart is more than the other type of cardiomyopathies. So those patients should also be anticoagulated. So if you have any question, she worth a big hand.